Okay. Good evening. Today's class is, my name is Manish. I'm final year PG in Orthotics, and the topic I'm going to be discussing today is torticollis. Now, what is torticollis? Torticollis, or as a layman calls, wry neck, is a common clinical symptom and sign found in a variety of situations. It is a rotational deformity of the upper cervical spine that causes a turning and tilting of the head. The head is tilted to the inward side and the chin is rotated to the opposite side. This is most often seen in the newborn period and is often associated with deformity of the head, which is called as plagiocephaly. Plagiocephaly usually entitles a flat spot on the head because the child often holds his head at an angle. And the torticollis is present in the newborn period. The usual cause is usually congenital muscular torticollis. Dia aku sendiri yang senja. Dia tu kan yang kita pada. Ini mana ada ini scenes atau mana ada jalan. Kalau ya, ambil apa? Okay. Sorry for the interruption. Torticollis. X-rays of cervical spine, however, should be obtained to exclude other less common congenital conditions such as fixed or bony torticollis, resulting from triple file syndrome or other anomalies of the atlantoaxial portion of the cervical spine. Torticollis may also be seen following a childhood upper respiratory tract illness. We'll discuss more about that later. And when torticollis is present after a newborn period, one should highly be suspicious of a problem in the upper cervical spine, as 50% of the rotation of cervical spine occurs at C1 or C2, the atlantoaxial junction. Therefore, conditions that would cause a rotational deformity are likely to present at the atlantoaxial level. This is a child which is displaying the characteristic signs of torticollis, with the chin pointing to the opposite direction and the head tilted to the other side. And we'll discuss more about that lump later in that anatomy. See? And the head is tilted to the other side with the chin to the opposite side. And because of that posture, the sternocleidomastoid muscle on the opposite side of the tilting of the head, it stretches from the sternum to the skull behind the ear, which results in a taut sternocleidomastoid muscle, as you can see. And wry neck is the term which is derived because of that taut muscle. Now, this is a child. Here again you can see that the chin is tilted to the opposite side, whereas the face is shifted to the other side. This presentation like this may either be congenital muscular torticollis or a rotator subluxation of atlas and axis, which can be differentiated by radiographs and CT or MRI scans. This child also has facial asymmetry. Now, coming to the pathanatomy, the lesion which results from usually results from fibrosis of sternocleidomastoid muscle, and the mass can be palpated within the affected muscle. Histological findings are characterized by deposition of collagen and fibroblasts around the atrophied muscle cells. And congenital muscular torticollis is usually discovered within the first month of life, and it presents as unilateral tightness of the sternocleidomastoid muscle, and 75% of involved muscles are on the right side. There may be a palpable mass or tumor that is generally non-tender, which is firm to soft, and it is mobile beneath the skin, but it is mobile only in the plane of the muscle, not in every plane. And it is attached to or located within the body of the sternocleidomastoid muscle, which is the previous one. You have seen the picture. See the lump there? that comes from, that is the tumor that they are talking about. This mass, it often enlarges during the first 4 to 6 weeks of life, and then it gradually decreases in size, and by 4 to 6 months of age, the mass is usually absent, and the only clinical findings that may remain are the contraction of the sternocleidomastoid muscle and the torticollis posture, with the head tilted towards the involved side and the chin rotated towards the opposite shoulder. It usually disappears within the year, and if it fails to disappear, then the muscle becomes permanently fibrotic and contracted and causes torticollis. Again, torticollis is just a sign. Asymmetry of the face and skull, called plagiocephaly, may be seen in rarely untreated cases. This is caused by sleeping position of the child, especially when lying in prone position with the affected side down. It results in a flat spot on the skull. Now, Grisel syndrome. Atlantoaxial subluxation, secondary to upper respiratory tract infection in the children, may present as torticollis, which is called Grisel syndrome. Coming to the theories of origin of torticollis, the primary theory is the malposition of fetus in utero, in uterine driving, classically in congenital, in twins and twin pregnancies and like that. And primary neurogenic cause, like spinal accessory to clavicular head getting entrapped, and it causes progressive deformity. This is more acquired torticollis. And mesenchymal cells remaining in sternocleidomastoid from fetal embryogenesis, leading to their proliferation, or any vascular injury which may be either intrauterine or perinatal compartments. Now, these are Cheng divided the muscles into, depending on the muscles, he differentiated cases into different clinical groups. The first group is sternomastoid tumor group, those with a clinically palpable sternomastoid tumor. The other is the muscular group, those with clinical thickening and tightness of the sternocleidomastoid muscle. The other is postural torticollis, those with the postural head tilt and clinical features of torticollis, but without the tightness or the tumor of sternocleidomastoid muscle group. Coming to differential diagnosis, the causes of torticollis is diverse, and identifying the cause can pose a difficult diagnostic problem. Radiographs are often difficult to obtain because the mastoid overlays the upper cervical spine, and a radiograph of the cervical spine taken as lateral to the skull can imagine the atlantoaxial region where the problem usually exists. If congenital muscular torticollis is not present, there may be an odontoid anomaly, an atlantoaxial instability, Klippel-Feil syndrome, or any other thing. All the children with torticollis should be evaluated with X-rays to exclude bony abnormality or fracture. X-ray evaluation may be difficult in any child with rotational deformity, but this is particularly true in the neonate. This is a chart with differential diagnosis of torticollis. Congenitally, the differential diagnosis Klippel-Feil syndrome. Just look at the chart and Atlanto-occipital fusion or pterygium coli. Pterygium coli is a condition where, because of the tilted nature of the head, the skin develops folds and webs, which is classically described as pterygium coli. Neurological things which mimic torticollis or ocular dysfunctions, syringomyelia, spinal cord tumors, or bulbar calcis, and these are inflammatory and traumatic causes of torticollis. More of the same here. Now, coming to clinical and radiographic features, if torticollis is noted in the weeks following delivery, the usual cause is congenital muscular torticollis. If a child is less than 2 months of age, the palpable lump is usually diagnostic. Congenital muscular torticollis is painless, and it is associated with a contracted sternocleidomastoid muscle and is unaccompanied by any bony abnormalities or neurological deficits. Any findings of pain or neurological deficit should lead one to seek out other causes, because torticollis is usually painless. Soft tissue problems are less common and include abnormal skin webs or folds. Tumors in the region of sternocleidomastoid include brachial cleft cyst and teratomas, which are rare but should be considered. In later childhood, bacterial or viral pharyngitis on the involvement of cervical nodes is the primary cause of torticollis. Spontaneous atlantoaxial rotatory subluxation may follow an acute pharyngitis. Radiographic confirmation is difficult, and computed CT scans and MRI images may be necessary for diagnosis. If torticollis goes untreated for more than several weeks, there may be secondary soft tissue deformities that result in fixed rotatory subluxation. Traumatic causes should be considered and excluded as part of evaluation. Torticollis most commonly follows injury to the C1-C2 level, atlantoaxial junction, and the fractures of the odontoid may not be apparent in the initial radiographic views, and if a high index of suspicion is present, then special radiographic study should be undertaken. Children with bone dysplasia such as Morque's disease and spondyloepiphyseal dysplasia and Down syndrome have a high incidence of C1-C2 problems and should be evaluated if torticollis is present. Neurological problems, particularly space-occupying lesions of the central nervous system, such as tumors of the posterior fossa or spinal column and syringomyelia, may be accompanied by torticollis. Generally, there are additional neurological findings such as long tract signs, weakness in the upper extremities, and hearing or visual problems that may also cause head tilt. Coming to Kaja anatomy, congenital muscular torticollis is believed to be caused by local trauma to the soft tissues of the neck just before or during delivery. 2/3 of the children are associated with difficult labor and delivery, and these children often have a breech or difficult forceps delivery, which might be the cause to a local trauma to the soft tissues. Torticollis can also occur in normal deliveries, however, and has been reported following cesarean section. Fibrosis in the muscle may be due to venous occlusion and pressure on the neck and the birth canal because of cervical and skull position. The persistent clinical deformity is probably related to the ratio of fibrosis in the muscle to the remaining functional muscle. If the fibrosis is more, then the deformity will be more. If sufficient normal muscle is present, it usually stretches with the growth and the child does not develop torticollis. In 3 of 4 children, the lesion is on the right side, 75% of the cases. Up to 20% of these children have congenital dysplasia of the hip associated with torticollis. Natural history of the disease. If the condition is not treated, then considerable cosmetic deformities of the face and skull can result, including asymmetry of the eyes and ears. There will be flattening of the face on the site of the contracted sternocleidomastoid, which may be impressive and is due to the position of the head when the child sleeps. Flattening. If the child sleeps prone, it is more comfortable to have the affected side down. The face of the affected side remodels to conform to the surface. That is called plagiocephaly, abnormality in the shape of the skull. In children who sleep supine, the modeling of contralateral aspect of the skull is evident. Whichever part of the head comes into contact with the hard surface of the floor, that remodels to conform to the surface. So that is called plagiocephaly. The immediate cause of deformity is fibrosis within the sternocleidomastoid muscle. The more the deformity, the more is the fibrosis, which subsequently contracts and shortens. The exact pathogenesis of the fibrosis is unknown, maybe due to trauma or any cause, but edema and lesion of the muscle fibers and acute inflammation leads to fibrosis. Differences between congenital and acquired torticollis. It's only called congenital torticollis if the onset is within weeks of birth, preferably 4 to 6 weeks. And any other associated problems are usually rare because within 1 year the child will, the muscle will heal and the child will revert to his normal position. Anish. Acquired torticollis. Acquired torticollis. The onset usually occurs in later life, and it is usually accompanied with many other associated problems like neurogenic and inflammatory acute myositis, infectious causes such as retropharyngeal abscess, cervical adenitis and tonsillitis, or any other brainstem or neoplastic lesions, or Atlanta axial subluxation. All these causes come under acquired torticollis. Depending on the lesions in the muscles, they are divided into intrinsic and extrinsic lesions. Intrinsic lesions. Hematomas of the sternocleidomastoid muscle follow trauma, but congenital torticollis is thought to be due to injury or hematoma of muscle at birth. Another intrinsic lesion is cervical fibromyositis. In this condition, the head is usually held in one position. And the extrinsic cause for cervical ribs and scars of the neck, tonsillitis, dental abscess, or cervical adenitis may also cause torticollis. Nerve and nerve root. Conditions of the spinal column such as cervical spondylosis, tuberculosis of cervical vertebra, dislocation or fracture of the cervical spine, and cord tumors can also cause this disorder. Coming to the central nervous system, tumors of the brainstem and cerebellum can cause torticollis. Some cases are due to post-infectious encephalitis and cerebral palsy. Drugs such as phenothiazines and L-DOPA may be culprits. Supratentorium. Spasmodic torticollis would seem to fall into this category. We'll discuss more about spasmodic torticollis in the coming slides. Injury, especially if he or she is wearing a cervical collar. Hysteria may also cause torticollis. These are the different pathologies which may cause torticollis, marked out. Coming to the management, excellent results can be obtained in most patients with stretching exercises. In childhood, in congenital torticollis, nothing else is needed in most of the cases other than stretching exercises. The child naturally heals and goes back to its natural contour within 1 year. And these exercises include positioning the ear opposite to the contracted muscle to the shoulder, and also stretching the chin to the shoulder on the opposite side. When adequate stretching has been obtained in neutral position, these maneuvers should be repeated with the neck extended. Other measures include positioning of the grip toy so that sternocleidomastoid muscles are stretched when trying to reach or grasp. If these exercises are unsuccessful, then surgical resection may be required to release a portion of the tendon at its clavicular attachment. Surgery is usually performed before school age. Asymmetry of the skull and face corrects as long as adequate growth potential remains after the deforming force of sternocleidomastoid is removed. The results of surgery are usually good, with a low incidence of complications and recurrence, although some children require a repeat procedure during adolescence. More severe deformities may require both proximal and distal sternocleidomastoid release. Now, coming to spasmodic torticollis, this is an independent condition. It's usually uncommon. This is an uncommon condition that may present in adults with painful spasms producing a Y-neck deformity, where radiographic studies are usually known. The cause is idiopathic. However, electromyographic studies show involvement of many muscles in the area, including sternocleidomastoid, trapezius, and splenius. This condition is resistant to the usual forms of treatment, including surgery. Often these patients have concomitant or they develop severe psychiatric disturbances. The cause, as I said, the cause is idiopathic. Its pathogenesis is not clearly understood. Treatment consists of intradural section of the spinal accessory nerves and first 3 anterior cervical nerve roots. Minimal involvement on one side and severe involvement on the other may require nerve root section on one side only. When the pain is intense and bilateral and many muscles are at fault, a section of the 4th anterior cervical nerve root may be added without fear of compromising diaphragmatic function. Postoperatively, the neck function is weak, but patient's painful spasms have improved. Neuritis of spinal accessory nerve can present much like spasmodic torticollis. This condition is however temporary and usually resolves in a few weeks with application of heat, rest, and occasional local injection of spinal accessory nerve. This is a picture of acute torticollis due to neuritis of spinal accessory nerve, and severely painful spasms were usually unilateral, temporary, and they are relieved by infiltration of the nerve with a local anesthetic. In contrast, spasmodic torticollis is bilateral and persistent, and it is unaffected by injection of the nerve.